today, and we're also very lucky to have Matt Golden here, who's a professor of medicine, Division of Infectious Diseases, and the director of Public Health Seattle-King County HIV/STD program. And he's going to talk to us today about anal cancer. Should screening be routine? So, Matt, take it away.
All right. Well, thanks a lot for including me in this. So what I'm going to briefly talk about is anal cancer screening, which is quite a controversial issue related to HIV care and, in particular, care of men who have sex with men. And when one thinks about a new screening intervention, you go through a number of questions. Does the burden of disease warrant action? Is this an important medical problem? Are the components of the intervention known to be effective, which in this case would be anal pap smears and then followed up by high-resolution anoscopy and biopsy? Can we treat these abnormal lesions? Can providers manage this, and will patients agree to do it and follow through? And does the early diagnosis and treatment change clinical outcomes? And then finally, can we afford this? So I thought we'd go through data related to these points and try to come to some kind of at least provisional conclusion. As probably all of you know, anal cancer is caused by human papillomavirus. There are over 80 types of human papillomavirus that affect humans, but most of the cancers are caused by 16 and 18, while 6 and 11 are the most common causes of warts. Almost all sexually active Americans have been infected with at least one HPV type. Among HIV-positive men who have sex with men, over 90% have infections, and the vast majority have had at least one oncogenic infection. So this slide is showing you rates of anal cancer among HIV-positive MSM in San Francisco. Overall, although estimates have varied, it's thought that the anal cancer incidence is about 46 per 100,000. And it looks like the risk is going up. So on the slide, you can see comparing 80 to 89, 90 to 95, 96 to 90, 2006. There is this apparent increase, although more recent data would also suggest perhaps this is leveled off. Despite that, it's quite a rare cause of death. So less than 1% of deaths in people with AIDS are attributable to anal cancer. So extremely common infection, actually normative to have the infection, very common to have abnormalities, not very common to die. In terms of risk factors, lower nadir CD4 count is associated with a greater risk, and also older age. Antiretrovirals don't appear to lower your risk. And so what we really end up with is kind of these divergent trends. So people aren't dying from other things, which means they have more time to get anal cancer, probably driving this increased risk, although some of it is likely ascertainment. On the other hand, fewer people have low CD4 counts, and that should diminish the risk of anal cancer, particularly if we can be successful in getting people diagnosed and treated early in the course of their infections. Now, some of you probably remember that in medical school, they taught you that the progression of HPV infection to invasive cervical cancer was this neat unidirectional process, which was good from a perspective that you could memorize it for the test, but it turned out it was wrong. And instead, what you have is a much more of a dynamic, where people become infected, and in the cervix and probably in the anus as well, you go to low-grade lesions and then to progressively higher-grade lesions, but people move back and forth between these and clear the infections as well. So while it's true that a high-grade lesion is worse and more likely to progress to anal cancer, there is regression as well. It's a dynamic. So if you think about a screening algorithm, what you start with is an anal pap, followed by high-resolution anoscopy and biopsy, followed by treatment. And the problem here is that the PAPs, the prevalence of the abnormalities is extremely common. And while the sensitivity isn't bad, the specificity is very bad. And so the positive predictive value of an abnormal anal pap is under 50%. And most people, about half of people are going to have an abnormal anal pap. And if you do them serially, almost everyone will eventually have an abnormal anal pap, which means they're going to have to go for high-res anoscopy and then treatment. Well, what does it mean if I have 5,000 HIV-positive MSM? Well, about 2,500 are going to have an abnormal initial test. They're going to have to go for high-resolution anoscopy and biopsy, of whom about 125 are going to require treatment. And the risk of anal cancer would be in the neighborhood of 3 to 5 cases per year in the absence of screening. We have no idea really what the risk would be in a screened population. We don't have those data. The point simply being that if you initiate a screening program, you're going to have a lot of abnormal results and you're going to require a lot of follow-up. Now, in terms of the treatment, to date, there is only, to my knowledge, one randomized controlled trial evaluating different treatments for anal intraepithelial neoplasia, which was presented at CROI this year. It was 140 HIV-positive men who have sex with men. Actually, only 60% had high-grade lesions. So some of these people probably wouldn't really be treated for the most part. And they were randomized to receive Imiquimod 5-FU or Electrocautery. And I'd point out that in the United States, mostly the dominant treatment is infrared photocoagulation, so not exactly this Electrocautery, a variant on it. And they were followed up. What they saw was the Electrocautery was the best intervention, which is the closest to what's being used in the United States, with complete remission 41% and partial remission an additional 7%. But recurrence is common, and pain is common. The Electrocautery was the best, but it still wasn't entirely benign. And recurrence, this is at 6 months. If we look then over a longer period of time, looking at what we use, which again is this infrared coagulator ablation, this is the largest single study we have on this, which is only 96 people, I point out. In HIV positive people, by 2 years, you're over 70% recurrence. So yes, the intervention does at least transiently resolve the problem, but it doesn't, for the most part, lead to a permanent resolution to the problem. So you're in a cycle of ongoing screening is, I think, what's really key, if one elects to do this. Will the patients agree to do it? It looks like it depends a little on where you live. So in San Francisco, in Joel Pilevsky's clinic, the answer I would say is yes. They do follow up 80%. In San Diego, not so much. In San Francisco is the place where this has been most aggressively pursued and researched. And I think Joel probably has the premier clinic, although I don't doubt there are other people who have good clinics. So it really highlights that if you're going to do something like this, it requires a lot of organization. Is it cost effective? Well, what data we have would suggest it is cost effective. This is data from a study Sue Goldie did in JAMA. And this is a little bit of a hard slide to follow, but if you look at incremental cost effectiveness, typically under $50,000 a year is felt to be cost effective. So under most assumptions, this was thought to be cost effective. So the argument for the screening is that this is an important problem, and it causes morbidity and mortality in MSM, particularly HIV positive MSM. The anal paps can identify abnormalities that are likely precursors to cancer, and there's some evidence to suggest that decreasing these abnormalities decreases their progression. There's also some evidence that suggests it's cost effective. And although we don't have direct evidence that screening decreases cancer morbidity and mortality, pap smears are thought to work for cervical cancer, and the rationale for screening for anal cancer is similar, and we're never likely to have a definitive trial, so we should just move forward. That's the argument, we should do this. An argument against it goes something like this. Yes, it's an important problem, but the anal pap smears are so nonspecific that almost everyone's going to need a biopsy. And treatment isn't known to be effective. And existing evidence related to recurrence rates suggests that they're extremely high. That the analogy to cervical cancer is false, because loop excision cervical cancer removes a lot of tissue, whereas what we're doing for anal cancer is not really exactly the same. And it's uncertain whether providers and patients can even do it. Moreover, if you think about cancer screening in general with prostate cancer, I think our recent experience is a cautionary tale as we're moving away from so much routine screening with weak evidence. So if I look at this overall, I would say the burden of disease is significant. I would say we're uncertain if the components of the intervention are effective, and we're uncertain whether we can really manage this and whether it will change clinical outcomes. And I also would say we're uncertain that we can really afford it. In terms of where we stand with recommendations, the New York State Department of Health does recommend anal paps, but they're the outlier. So CDC does not, the U.S. Preventive Services Task Force does not, the American Cancer Society does not, the IDSA does not. If you're going to do this, the idea would be to do a baseline anal pap, and then in positives you would do them twice a year until they were consistently negative, and then annually. And you would have to refer people for high-res anoscopy if they had cytology which showed atypical squamous cells of uncertain significance or worse. My perspective is, it works? I'm not sure. Could we even study it? So I'm not sure we could ever do a large enough study. And part of it has to do with what would your evidentiary standard be. So if you wanted to look at cancer death, which was what was done with prostate cancer screening, you would need tens of thousands of people. It would be a huge undertaking. If we want to look at anal cancer but not death, we'd still need thousands of people over many years. And there'd be a concern that the screening would increase the detection of the anal cancer and that you'd have false signal on this. And if we just use AIN as an outcome, I'm not sure it would be convincing. Now, the one thing to me that is convincing is that HPV vaccine is an effective intervention. So we know from a randomized controlled trial that this is 76% effective in preventing 16, 18, 6, and 11 associated AIN and MS, men who have sex with men. And this picture I have here is from an observational study looking at recurrence rates in people who had high-grade AIN among people who got the quadrivalent HPV vaccine versus those who didn't. And what you can see is that recipients of the vaccine had a lower rate of recurrence. So some suggestion in this that even in people who already were infected, that the vaccine was having a beneficial effect. I grant you, not a randomized controlled trial. So my conclusion is that this is an important problem. It's probably growing, but it's a rare cause of death. And that while the rationale for anal pap screening is strong, and it's probably safe, the effectiveness and cost effectiveness are not known and may not even be knowable. I think optimally, men who have sex with men would know that anal paps are available and know something about them, but I don't think that the data are strong enough to make a firm recommendation that this should be done. This is one more reason to treat people while their immune systems are strong, which is, I think, justified for many other reasons. I would also point out we really need to make sure that all young men under age 26 are vaccinated for HPV. And I'd say the role in older men is less certain, but it isn't unreasonable to vaccinate people based on the limited data we have. Of course, whether it's covered, I'm not entirely sure in the older guys.